All right, let's dive into parasitology. It's pretty amazing how some of the most complex clinical pictures can start from the absolute smallest of events. Today, we're going to trace the path of lymphatic filariasis, and we're going to follow it all the way from a single mosquito bite to a truly life-altering disease. We'll break it down into a clear, understandable clinical pathway. Let's get started.
So, this is the big question we're going to frame our entire explainer around. How does a single mosquito bite lead to something as severe as elephantiasis? It's a pretty dramatic outcome, I know, but understanding that whole journey, from a microscopic larva all the way to severe lymphatic obstruction, is absolutely the key to mastering this topic.
Okay, here's our game plan. We'll walk through this systematically. We're going to start with the culprits themselves, trace their really intricate life cycle, then map out the disease they cause. And from there, we'll cover the clinical essentials, diagnosis, and treatment. It's a logical flow designed to build your understanding step by step.
First up, let's meet the causative agents and see exactly where in the world they're found.
Okay, so we've got two main players here, and it's really interesting to see the distinction. On one side, you have Wuchereria bancrofti. Think of this one as the world traveler. It's in tropical areas everywhere. But, and this is a key point, it's strictly a human pathogen. On the other side is Brugia malayi. This one's a bit more of a homebody, restricted to Southeast Asia, and it's not as picky about its host. It infects humans, sure, but also wild and domestic animals. Now you can imagine how that difference has some major implications for control strategies. But despite those differences, here's the crucial thing they share. The common denominator is the mosquito. Both parasites rely on a mosquito vector to complete their life cycle and spread to new hosts. That makes mosquito control a fundamental, non-negotiable part of preventing this disease. Okay, let's move on to the life cycle. This is where the story gets really fascinating, and it's where we'll see how understanding the parasite's biology helps us understand the pathology. So just take a look at that number, 10 centimeters. That's how big an adult female worm can get, and it's living, reproducing, and eventually dying inside our own lymphatic channels. I mean, that is a remarkably large parasite to be living inside such a delicate system. And then, in total contrast, you have their offspring, the microfilaria. At just 260 micrometers, they are completely microscopic. This is the stage that's actually circulating in the blood, and as we're about to see, it's the form we're hunting for when we make a diagnosis. The size difference between parent and offspring is just staggering. So this slide lays out the entire two-host cycle. Let's follow the path. It all starts with an infected mosquito bite, injecting these little larvae into a human. Those larvae then make their way to the lymphatics and take about a year to mature into those big adult worms. The adults then reproduce, releasing tons of microfilariae, which then migrate into the blood. But here's the really clever part. They do this mostly at night. The timing is perfectly synced up for a nocturnal mosquito to come along, take a blood meal, and swallow them up. Then they develop inside the mosquito for a couple of weeks, and the whole cycle is ready to start all over again. Now that we understand the parasite's life, let's look at the consequences for the human host. What does this infection actually look like in a patient?
Well, the disease progresses in pretty distinct phases. In the acute phase, you see patients with these cyclical high fevers maybe every couple of months, along with painful swollen lymph nodes. That's the lymphadenitis. This is all being driven by the host's inflammatory response to the living worms. But the major lasting damage actually happens later, in the chronic phase.
And this quote right here, this is the key pathological event. It's not the living worm, it's the body's super intense inflammatory reaction to the dead and dying adult worms that causes the real problem. The body forms what's called a fibroproliferative granuloma. So let's break that down. Granuloma is just a ball of immune cells. Fibro means it's creating fibrous scar tissue, and proliferative means it just keeps on growing. So you end up with this big, scarring mass that physically blocks the lymph vessel, and that blockage leads to all the downstream swelling, the lymphedema.
So along with that lymphedema, you'll see other classic signs. Your lab work will almost always show a high eosinophil count, which is totally typical for a parasitic worm infection. You might also find some spleen enlargement. And critically, from a clinical standpoint, the skin that's stretched over those swollen areas becomes really fragile. It's super prone to traumatic injury and, importantly, secondary bacterial and fungal infections, which can just make the whole condition dramatically worse.
Now, it is really important to stress this point. While elephantiasis is the most dramatic thing we see, it is not an inevitable outcome, not even close. Many infected people might have much milder symptoms, or even be completely asymptomatic. If that severe lymphatic damage can be avoided or managed, the prognosis is actually pretty good.
Okay, so how do we confirm our suspicions? Let's walk through the diagnostic workup.
I want you to think of the diagnosis as a triad, 3 key pieces. First, the patient's history. Have they been in an area where this disease is endemic? Second, the clinical picture. Do they have those characteristic fevers and swollen lymph nodes? And third, the definitive proof, finding the microfilariae in a blood sample. And you see that crucial detail there? The sample absolutely must be collected at night.
So why the specific timing? Why is a night blood sample so critical? Well, this brings us right back to the parasite's life cycle. The microfilaria show what's called nocturnal periodicity. They're most abundant in the peripheral blood at night, which maximizes their chances of being picked up by a feeding mosquito. If you take a sample during the day, you're very likely to get a false negative. It's just a perfect example of how basic parasitology directly informs our clinical practice.
All right, we've identified the intruder. Let's wrap this up with how we actually treat the infection and manage the patient.
The mainstay of treatment is a drug called diethylcarbamazine. You'll see it called DEC. It's effective. It either kills the adult worms or it sterilizes the females so they stop producing microfilaria. But as the worms die, they can provoke that strong inflammatory reaction we've been talking about. That's why steroids are often given as an adjunctive therapy. You give them alongside the DEC to help dampen that inflammation and manage the patient's symptoms during treatment.
And here's a simple, non-pharmacological tip that can genuinely help a patient. If it's possible, moving to a cooler climate can actually help reduce the severity of those inflammatory reactions. It's a small but really practical piece of the management puzzle.
So if you take one thing away from this entire explainer, let it be this. From timing our blood draws to understanding the pathology of lymphatic blockage to targeting mosquito vectors for control, a deep understanding of the parasite's life cycle is absolutely fundamental. It is the key to both clinical management and public health control. And that leaves us with one final question to think about. We have an effective drug, we totally understand the transmission cycle, so why does lymphatic filariasis still affect millions of people all over the world? What are the real-world barriers, the social, the economic, the logistical barriers that are standing in the way of global eradication? Definitely something to think about. Thanks for watching.